Thank you very much for the invitation to come and speak with you today. It's a great privilege, and I acknowledge the beautiful country that we're meeting on today and the custodians. I also acknowledge that I live on the lands of the Kaurna people, so thank you. I acknowledge you, and you two are a very hard act to follow, so feel free to be less inspired because I just cannot meet that standard. But anyway, let's have a little go. So I've got two projects that I wanted to talk to you about. About state-wide reforms in South Australia. The first one, forgive me, I'm going to talk about a metropolitan project, and I know that you're very deeply committed to rural and remote healthcare, so I'm going to ask you to imagine that Adelaide is a big country town. And I know Victorians like to think that. So I come from a little country town, and I'm telling you Adelaide's not, but that's what I'm going to ask you to imagine. So we're going to talk firstly about the metropolitan stroke service reforms, because that's a really important part. We couldn't have done the rural reforms until we had sorted metropolitan care out. So firstly, stroke. 1 in 4 Australians are going to have a stroke. It costs a lot of money. It kills more women than breast cancer, more men than prostate cancer. It's not a competition, I know that, but I just want people to take it seriously as a mortality risk as well as a morbidity risk, because 65% of stroke survivors go on to have a disability that impacts their very most basic activities of life. So we're not talking a trivial issue here. You don't need to know the South Australian statistics, but they're important. I think the key one there is that people think stroke is something that happens to old people. It doesn't. It happens to all of us. So this first reform, called Transforming Health, anybody who has worked in the public health system in South Australia around transforming health gets triggered by that term, because it was quite a traumatic, massive reform agenda for health, which in many ways didn't work for various reasons. But I'm really happy to say that for stroke it did work. And I hope you'll agree with me after this first couple of slides. Transforming Health was a statewide health system, tertiary health system reform, and it was data-driven, which showed that, particularly in my area for stroke, we had worse services and worse outcome depending on what time of day you had your stroke and where you had your stroke. Now that was even in metropolitan Adelaide, had different rates of mortality according to where you had your stroke. So, and if you had it overnight, then you were going to have a lot worse outcomes as well. So this is not acceptable. So Transforming Health had a very strong framework across other diagnostic groups and other services as well, but particularly for stroke, for a different model that was equitable and based on evidence. And these are the things that I think are really important, understanding around translating evidence into practice. So what we were interested in, particularly the evidence base, says that stroke care delivered in a stroke unit saves lives and it reduces morbidity, it reduces the effects of stroke. So what's in a stroke unit, it's team-based, it's 7 days a week, it has communication, funnily enough. People talk to each other, teams talk to each other, and the family and the client are part of the team. And it has goal setting and integrated care specialist services. So that saves lives. The other thing that saves lives is rapid neurointervention. That's going in and giving medication that breaks the clots that are causing the stroke, or actually going into somebody's brain and removing the clot. So these are the neurointerventions. So these 3 aspects of evidence-based care that we didn't have consistently. So, I've listed those there. And the evidence has been around for a long time. It's been demonstrated in other countries. And the new model that we proposed in South Australia was based on a London model and a Manchester model. So it was based on the right help at the right time by the right people for all South Australians. So what the reforms were basically, this is the old RA, that Kelly's talked about. That could be a little bit triggering too. It's my alma mater as well. So the old RA, the Lyell McEwin Hospital in the north and the Flinders Medical Centre in the south of the metropolitan area. So we had a hub and spokes model, so that the new RA, which happened at the same time, as if too much change is barely enough. So we moved the old RA to the new RA, and that became the hub, and the Lyell Mac and the Flinders Medical Centre became 2 metropolitan spokes. So on the left, on your left, is the pre-Transforming Health thing, where someone had a stroke and they went to one of 4 hospitals, which None of them had 7-day stroke care because they didn't have allied health on the weekend. And as you can see, some had the TPA, the clot busting drug, and the EVT is the going in and removing the clot. And you can see that was only available 24 hours a day in one hospital and for various random hours at the others. Whereas in the new Transforming Health, you have your stroke, and if you're living in the central area, retrieved to the hub. If you're within the 12-hour window, you go to the northern or the southern spokes, and if you're outside of the 12-hour window, you're retrieved to the central hub. So this is massive system reform, and it took a long time. So what we did, that's the reform. We had the funding to evaluate the reforms, and I'm grateful to HTSA, it's our Health Translation SA, is the equivalent of Western Alliance, with their rapid translation grants, and we had 2 grants to evaluate these reforms. So we looked at the stroke data before the reforms, during the reforms, and after the reforms. So in that period, there were nearly 4,000 stroke admissions, mostly ischemic, that's the clot-related ones. And these are the 3 time frames: before, during, and after. And the numbers there, probably, see if I can get the... they're not equal numbers, obviously, because they're different time periods, but basically what we showed was over the period, some of these basic things didn't change. Here's the 3 hospitals. We did see a bit of an uptick coming into the Royal Adelaide, as you'd expect. But the things we were worried about, that things would get worse because of extra transport, didn't happen. And in fact, what did get better, statistically better, was increasing the percentage of people who got that life-saving clot retrieval intervention. So we looked at mortality rates. Now this is a little something to just watch. During the implementation period, the transition period, more people died. Statistically, in reality they did, and we have to accept that change isn't always easy, and there is some chaos and churn in the system when you're trying to change it. However, the post-implementation period mortality has now come back, and it's actually continuing to improve since this time. We looked at quality indicators, a composite of about 12 different quality processes, and that has improved since pre-implementation times. And also length of stay has reduced, so there's something for everybody there. Mortality is okay, people are happy now. We haven't got that situation anymore. Quality has improved and the funders are happy because people are moving through better. So the impact is that this massive big change in our structure did lead to some increased mortality, did improve people getting access to this life-saving intervention, and did improve care indicators and length of stay. Probably one of the most important things is that we showed that data collection in an ongoing, sustained way is really important so that we can monitor ongoing quality improvement projects. So now we've also convinced the government to pay for regular data collection that goes into a federal data registry for stroke. So this is the one you're probably more interested in, which is the SA Regional Telestroke Service. Well, we couldn't do this until we had things sorted in the metropolitan area. So rural and regional Australians are 17% more likely to have a stroke than metro colleagues. And stroke-related in-hospital mortality is higher in rural Australians. Evidence from other countries suggests that telestroke services can help. So what did we implement next? Before the implementation, we simply had a registrar-supported reperfusion, that's the clot-busting intervention, advice only and only in business hours and only at 3 regional hospitals. And for those who weren't eligible, which is probably another 72% who don't get reperfusion, basically got no specialist care. So post-implementation, a single statewide number, 24 hours on call for support for all the telehealth, retrieval to the nearest regional hospital, which needed this multimodal CT imaging, which is necessary for safe reperfusion. A video conference with the neurologist in the central area, with the regional practitioner and the patient and their family with the neuroimaging, and then a comprehensive treatment plan. So you can see it's a very different service structure. So these are, again, massive reforms. So how did we do that? Many years of discussions and lots of travel, a partnership, strong partnerships between the stroke unit at Royal Adelaide, between Country Health and the AMBOs, comprehensive education at the local level, very, very clear protocols so that everybody's doing the same thing, as well as the bypass protocols and guidelines. A big investment in more neurologists to run the telestroke from Royal Adelaide. A lot of media engagement, a lot of local engagement to increase awareness, and regular meetings for this bidirectional feedback. So what happened? I'm really happy to say that the annualised rate of people, remembering that people weren't getting to stroke care, an annualised rate of 105 post-implementation compared to 62. So that is a pretty impressive increase in number of people who are getting to a regional stroke centre. Mortality improved, 23% versus 13%. 23 was pre, obviously that's worse, 13 is better, a lot better. And the quality indicators that we also looked at improved, so the processes got better. Just to give you an idea of the quality indicators that look at things like the thrombolysis, but also whether people get the right medications to prevent another stroke, whether they get the right kind of assessments and the right kind of rehabilitation, risk factor advice, care assessments. You can see carer stuff needs a lot of work. So probably the most important thing for you, what are the lessons learned? Obviously these were massive reforms and they took years and years. There were a lot of years in the making and a lot of consultations and a lot of people working together with post-it notes and butcher's paper and texters and so forth. And we needed champions at every level. So in implementation, we talk about having a champion. We needed multiple. At the funder level, clinicians, all related organisations, services and stakeholders, all consumers, and of course, government. This kind of reform doesn't happen without having the government on board. We had both economic and equity drivers. These are really important so that we could say absolutely hand on heart, if we don't do this, it's not acceptable. And we had benchmark data against comparable systems elsewhere, and unequivocal international evidence for best practice. And then we co-produced, translated those best practice pieces of evidence into local protocols and guidelines so that were consensus-based, so that ultimately we could say hand on heart, we aspire to do the best equitably and effectively. And the cynic in me says this is what we were also saying. If we don't do this, this is deeply embarrassing and actually shameful. So we have to do it. And that's my other recommendation. You don't want to come out with that as you're fighting punch, but you do want your local politician to understand that if he or she doesn't support this, it's not acceptable. So a few people to thank. There's obviously hundreds and hundreds more about why these things are important. And thank you to the RAT funding to evaluate both of those projects so that we can actually celebrate that things are better. So often we implement something, how do we show that it is better, and that if there was ever any question about whether we should continue or not, we've got the data to say no, we need to continue because this is working, it's saving lives, and it's improving for the survivors, it's improving quality of life. If you have any other questions, you can email me. Thank you. I think I've saved you some time.
I think so. Now, don't run away. Any quick questions here? I'd love to take a quick question.
I think you've underplayed the amount of work that's been done. It's just phenomenal. I just want to ask a question. When you centralised EVT, and obviously that affects your medical workforce because you had your thrombolysis on the other sites. How did you go about that? And were people on the other sites still able to work in their central site to do EVT, because it's a skill in itself?
Yeah. This was a bit of an industrial issue because there's a bit of a bun fight amongst certain disciplines about who should do EVT. This is where we really needed that section of the community, to the disciplines, to come together and decide who was going to do it. The evidence base was pretty strong that you need currency. So you need to be doing this. EVT is when you thread a catheter up through someone's groin all the way up through to their brain and kind of bust up the clot in the brain. So you do not want somebody doing it once every 3 months or what. So there are international guidelines about how often people need to do it to have currency. And I have to say, in the first year or two, it made the headlines in the Advertiser about these. The Advertiser is the local rag. Sorry. It's a rag. It's a rag. About, this shameful thing that there were three medicos who can do EVT and all three were on holidays or something. It wasn't actually true. It was a beat up. Who knew that the Advertiser would beat something up? But the gist of it was actually true, is that it was a risk. And in the implementation plan, it had always been a high risk. And now there's a strong and stable pool of neurointerventionists who do that at the Royal Adelaide, and they maintain it at the Royal Adelaide so that they have the sufficient currency to do it. If it was distributed across other sites, they wouldn't have the currency. And these guys are expensive. I'm sorry to say they're guys, because they are. Hopefully there'll be some women soon too, but I shouldn't be gendered, should I? But so there was a huge issue about that. But what the people who were responsible for that side of things stuck to their guns, and they stuck to the evidence base and put that aside, and came to a consensus that that's what would happen in Adelaide. Now, of course, inevitably there are still turf wars very quietly going on in the background, and that has to be managed. But the long and the short of it is you can't afford to run these services at multiple sites. They are incredibly expensive.
Well done.
Yeah. So full marks to, particularly Tim Kleininger, Jim Janis, the neurologists, who were so diplomatic and so good at negotiating. Yeah.
Okay, join with me in thanking Susan.